Hello, everyone. Very nice to see all of you today. And I'm very happy to have our third webinar for our Neurocritical Care Fellowship. And today we are focusing on traumatic brain injury, which is one of the common and have very devastating consequencing neurocritical care events in our ICU. And the neurocritical care training is vital, not only for intensivist or critical care physician or neurologist, but for all of our healthcare professionals. And we should know if we are taking care of patients in ICU, the basic principle and how to improve our patients' outcome. A specialized team in neurocritical care unit have been shown to enhance recovery and also survival in patients with TBI, stroke, and also with seizures. It's not only that, but also early detection, early intervention is also very important to improve our patients' outcome and to prevent irreversible damage. Neurocritical care thrives on teamwork through multidisciplinary team between neurologists, intensivists, critical care physician, anesthesiologist, pharmacist, therapist, and others. And neurocritical care training foster communication and shared decision-making across discipline. Training encourage evidence-based practice and continuous learning. And neurocritical care patients often have cardiac, respiratory, and metabolic complication. So training is very important, not only from the neurological side, but also from other aspects as well. I would say any healthcare worker who is dealing with critical care patients with various neurologic disorder should join this fellowship, because there is no good reason not to do that, because this fellowship is very flexible, accommodate all of your need, and will give you very good training in the critical care, in the neurocritical care field. I'm going to share with you our agenda today and some basics about our fellowship. So basically, our agenda involves this brief introduction. Then Dr. Ayman Morish is going to give you very brief samples of our neurocritical care fellowship. Then Dr. John Thompson is going to give about 16-minute presentation unpacking mild to moderate TBI, focusing on basics. Then Dr. Muhammad Al-Dawood is going to focus on advances in TBI. Then we'll open the session for discussion with question and answer. Dr. Bastian and Dr. Ayman will do this. Then Dr. Ayman is going to give us the closing remarks. So thank you everyone who is attending this today. And we have great speaker, and we have this diversity between several countries, several specialties are joining us today. So in the World Institute of Critical Care and Emergency Medicine, we know that our retention is very low when it comes with monologues or one-way educational activities by giving lectures or through reading. So we try to engage our fellows in a discussion and clinical-based cases, and to improve their practice and to let them adopt our educational activities and learning objectives in their clinical practice. The Neurocritical Care Fellowship is 3 modules, 16 weeks each. This is real education, not based only on monologue or webinar or seminar, but it's a bi-directional education, and we are allowing our fellows to be actively engaged in the e-learning process. It's a wholly online with a lot of MCQs, evaluation and assessment, critical thinking, and appraisal, and we are gathering expertise from all over the world. So very important is not only we are giving you the knowledge, but we are helping you to adopt and to apply this knowledge into your clinical practice. So all of the scientific materials are released on a weekly basis in a smart platform. So our fellows will have username and password and will be seeing our materials 24/7 after they log into the platform. But they have the freedom to navigate throughout the scientific materials and educational content. But before the end of each week, they need to submit their tasks and assignments. And all of our fellows' activities and tasks are monitored through the platform with weekly quantitative and qualitative assessment. And upon completion of the fellowship, we expect our fellows to be expert, to graduate to a trainer and mentor level, and also to receive a graduation certificate from the American Association of Continuing Medical Education. With that, I'm going just to leave you with one message, that all of these educational activities, our aim is to improve our patient outcome and to improve the standard of care in our practice, because the great aim of education, not the knowledge itself, but the action. With that, I'm going to leave you with Dr. Ayman to lead this webinar.
Good morning, good afternoon, and good evening, wherever you are. So, mashallah, we have attendees from all over the world. I'm Dr. Ayman, the ICU consultant with the Geriatric Fellowship and the Nephrocritical Care. So, today I will just give you a brief about what to expect in our programs, inshallah. Our topic today is how to navigate the storm. So, navigating the storm mainly in the traumatic brain injury. So we will cover a wide range in the fellowship, but now we'll just give you like a brief about what to expect in our fellowship, from triaging in the ER, what the ABC, and up to the ICU and the post-ICU care. And this is one of the modules. It will be in the fellowship, covering also the big topic of stroke and also other neurological emergencies. So let's go for it. So our structure, as Dr. Amr, our president, mentioned, it's like in the beginning at the beginning of each week, we'll have a lecture. After the lecture, we have like a brief questionnaire. Then later on, we'll have a journal club with a discussion of the topic in each week. After this, again, there's MCQ just to make sure that we grab the important part of this journal club or the articles. And at the end of the week, we ended with a discussion about cases. We usually present 2 or 3 cases, and we'll have a discussion throughout the week until we grasp. And usually the discussion is like two-way. So the student or the attendee will put the questions, one of the experts will answer, and then go and forward until we all satisfy with the knowledge. Just briefly, let's say, for example, we have a lecture about the stroke. So as a quiz, you will see like something like this. What's the recommended time window for mechanical thrombectomy in acute ischemic stroke patient with large vessel occlusion, according to the updated guidelines? So if you can share with us on the chat, just pick, is it like 6 hours, 12, 24, or up to 48 hours? I will give brief break until we got some answers. Okay, so the latest recommendation, the stroke recommendation is in within 6 hours, but you have up to 24 hours with the latest Diffuse 3 and Dawn trial that it shows that there is a benefit up to 24 hours. And usually these are the practice according to the clinical criteria, clinical and imaging criteria. Most of the interventionists will do up to 24 hours. So after the questionnaire, after we collect all the answers, you will have like a journal club. We'll make it like present one of the updated articles. Like for example, this one, thrombus enhancement sign may differentiate embolism from arteriosclerosis related large vessels occlusion. We'll give some time for the reading. We'll not give it now because we have short on time. So we'll put the link. You can review it later. Then you will face like a small questionnaire just to make sure that we grasp or we focus on the important messages from these articles. So, like for example, this article, which imaging module or modality is mostly commonly used in to detect the hyperdense MCA sign in acute stroke cases. Again, I will give some time for the answers, but always remember that you are not all of you working on a high resources area and high resources country. So that's why our fellowship will focus on the wide range. So there is some countries they have limited access to the MRI, some countries even limited access to the CT. So that's why we'll try our best to give you a practice that you can do wherever you are, whatever resources you have, and you are more welcome to discuss this modality. So if it's the gold standard not available in your area or in your hospital, we can help you to go what's the best next module or way of treating and helping your patient. So the standard one is the computer tomography, the CT scan, and these are the rationale. Usually, you can detect it on the non-contrast CT scan. It appears like a dense signal, and as mentioned here. So after the journal club, there will be a discussion about cases. So again, and usually it's related to this week topic. So let's say, for example, the case, 65 years old male, came with a sudden right-sided hemiplegia and aphasia. So, what's the most likely interpretation of this finding of the non-contrast CT? Is it chronic ischemic changes, acute intraparenchymal hemorrhage, hyperacute MCA thrombus, or calcified meningioma? Um, Again, we'll just break for a few seconds until we got a few answers. So again, most of you got it. Usually, the actual fellowship is not that easy, but I'm just trying to give you an example of what to expect and what's the structure. So as you all mentioned, it's hyperacute left thrombus. And then we'll discuss about the rationale. So the explanation, the hyperdense MCA sign indicate acute thrombus, and you can see it by the arrow, and actually it's very clear. Usually seen in the first few hours of the acute ischemia. So now, without further taking of your time, I will introduce my friend, Dr. John Thompson. He's from Scotland, fellow of Royal College of Emergency Medicine, Royal College of Surgeons of Edinburgh, and he's currently one of the senior consultant in our King's College Hospital, London, which is just opened in Saudi Arabia in the city of Jeddah. Um, 1 second, and it will be all here. Okay.
Good evening. My name is Dr. John Thompson, and I'm a consultant emergency physician working at King's College Hospital in Jeddah. I'd like to thank the World Institute of Critical Care and Emergency Medicine for inviting me to speak to you this evening on the topic of the emergency department management of mild and moderate head injury. I am originally from Scotland, and I've been practicing emergency medicine for 26 years, the last 18 of those as a consultant, mainly in the United Kingdom, but also in Australia and now Saudi Arabia. Emergency departments all over the world see around 69 million patients every year who have suffered a head injury, with the vast majority of those, around 90%, suffering what would be classified as a mild head injury. These patients place a huge burden on our health resources. Demographics show that the majority of patients that we see with a head injury are either young males or elderly patients. In both these groups, there are two very different mechanisms of injury that we see. In the young males, this is predominantly due to road traffic collisions, whereas in our elderly male and female patients, this is usually due to unintentional falls. It should be remembered that this is likely an underestimate of the number of patients that we see suffering a head injury, as these numbers only represent those who present to our hospitals. In terms of the pathophysiology of head injuries, they are caused initially by external mechanical forces which impact the brain. This can lead to significant damage to both brain tissue and brain function. The primary injury occurs at the moment of impact and may involve contusions, lacerations, diffuse axonal injury, and hemorrhage. The secondary injury develops due to biochemical cascades following the initial trauma in the hours to days after the initial insult. This may result in cerebral edema, cerebral ischemia, and raised intracranial pressure, all of which may worsen the impact of the original injury. Other factors which may impact on the type of head injury experienced include the duration of loss of consciousness, if present, antegrade, also known as post-traumatic amnesia, and the imaging findings. Finally, the GCS, or the Glasgow Coma Score. This was developed in 1974 in Glasgow, Scotland, initially to assess the level of consciousness following a brain injury. It is comprised of three distinct components: an eye response, a verbal response, and a motor response, and gives a score out of 15. This mode of assessment helps to accurately differentiate between a mild and a moderate head injury. A mild head injury, by definition, will mean that when assessed, the patient will have a GCS of 14 or 15. This type of head injury is synonymous with concussion. Concussion is a condition that affects brain function. It is often short-lived, and most people make a full and complete recovery. It may comprise of some or all of the following symptoms: headaches, difficulty with sleeping, difficulty concentrating, or the patient experiencing mood swings. Clinical features of the patient presenting with a mild head injury may include a brief, usually less than 30 minutes, loss of consciousness, post-traumatic amnesia, or an altered conscious level. The patient may have some or all of these features. As I said previously, mild head injury accounts for the vast majority of head injuries that we see in our emergency departments and may present with very subtle clinical signs, meaning that a careful assessment is paramount. By contrast, moderate head injury corresponds to a GCS of 9 to 13. It's generally accepted that a score of 8 or less indicates a coma and is out with the scope of this talk. The emergency department management of both mild and moderate head injury is aimed at preventing secondary injury occurring and to identify patients who are at risk of deterioration and may require further specialist intervention. Like a lot of medicine, an accurate, detailed history is paramount to understand how the patient came by their injury, whether there are any red flag features either to the mechanism of injury or in the aftermath of the injury itself. The physical examination should follow an ABCDE approach, with spinal immobilization where appropriate, to ensure that any problems are identified and dealt with in order of clinical priority. If the patient is stable, then a more detailed neurological examination can take place, looking at conscious level, pupillary reactivity, evidence of focal neurology, and signs of basal skull fracture such as a CSF leak, hemotympanum, panda eyes, or Battle's sign. Once a detailed history and examination has been completed, we can then employ validated evidence-based head injury guidance, such as the NICE Head Injury Guidelines or Canadian CT Head Injury Guidelines, to guide which patients should undergo a CT scan. The CT scan is the gold standard investigation for our patients presenting with a mild or moderate head injury. Not all facilities have access to a CT scanner 24 hours a day, 7 days a week, and it may be necessary at times to transfer patients to an appropriate facility in order to get the CT. In other areas, there may be no access to CT whatsoever, and other methods may be required to decide which patients need to utilise these scarce resources, such as transfer to a specialist unit or an admission for observation in lieu of the CT. But by applying validated guidance, we should aim for a consistency of approach as to which patients should and shouldn't undergo a CT, thereby reducing unnecessary expense and exposure to ionized radiation when it may not be necessary. Just a brief word about MRI. Whilst it undoubtedly has a role to play in the subacute phase and may be beneficial prognostically, it has no real place in the acute assessment of patients with mild or moderate head injury due to safety, logistical or resource reasons. So in patients with a mild head injury, when is a CT indicated? Well, there are two phases of the presentation where it may be indicated. Within the first hour, it's indicated if any of the following are present. The patient has a GCS less than 15 at 2 hours or more post-injury. If there is evidence or suspicion of an open or depressed skull fracture, clinical signs of basal skull fracture that I mentioned previously, seizure activity post-head injury, and any focal neurological deficit. In addition, if there's been more than one distinct episode of vomiting, then the patient should undergo an urgent CT scan. Again, just to note that any one of these features, if they're present, would be an indication for CT. If there is no indication for an emergency CT scan within 1 hour, then an urgent scan within 8 hours may be indicated if there is any evidence of loss of consciousness or amnesia since the injury, plus any of the following features. Patient's age is greater than 65. There is a known bleeding or clotting disorder in their past medical history. It's deemed a dangerous mechanism of injury to sustain the head injury. Examples of this include a fall from a height greater than 1 metre, ejected from a vehicle, or a pedestrian or cyclist that has been struck by a vehicle. If there is greater than 30 minutes, retrograde or pre-traumatic amnesia. If none of the above exists, then there is no indication for a CT scan. A potential exception to this, however, is if the patient is on anticoagulant or antiplatelet treatment, then the guidance says that we may consider a scan within 8 hours, but it may not also be necessary. Please note that in assessing the patient with this antiplatelet treatment, that aspirin monotherapy is not included. So in a patient who has no features and is only on aspirin monotherapy, there would be no indication for a CT scan. In patients with moderate head injury, the indications for CT are essentially the same with one exception. And that exception is that if the patient presents with a Glasgow Coma score of 12 or less at their time of presentation. In that situation, they should undergo an emergency CT scan as well. It's important in the ED to do the basics and to do them well. Ensure airway patency and be cognizant of the likelihood of concurrent spinal injury, particularly the cervical spine. In the more severe, moderate head injury, it may be necessary to consider intubation to maintain airway patency and ventilation. We want to avoid hypoxia. There is clear evidence that this is strongly associated with increased morbidity and mortality in our patients with head injury. Likewise, we want to avoid hypo or hyperventilation. Hypoventilation, we know, leads to an increase in intracranial pressure, whereas hyperventilation leads to cerebral vasoconstriction and ultimately cerebral ischemia. Ideally, we want to aim for a PaCO2 in the range of 4.7 to 5.3 kilopascals. We want to avoid hypotension. Again, there's a strong association with increased morbidity and mortality. So it's important to maintain an adequate blood pressure, crucial to ensure cerebral perfusion. Permissive hypotension should be avoided in these patients with traumatic brain injury, as it's imperative to maintain cerebral perfusion pressure in the presence of potentially raised intracranial pressure. It's therefore appropriate to target a mean arterial pressure of around 80 millimetres of mercury. And this creates a fundamental shift in how we approach our patients and the mindset for trauma teams who aim to reduce bleeding. So with head injury, we want to prioritise cerebral blood flow over generalised trauma resuscitation principles when there is a potential of a head injury being present. This differential approach is critical for preventing secondary brain injury and improving our neurological outcomes. It goes without saying that it is extremely important to closely monitor all our patients with a head injury whilst they're in the emergency department. Vital signs, including oxygen saturation, hemodynamic status, are important to reassess, as I've already for reasons that I've already mentioned. The frequency of neurological observations, including GCS and pupillary reactivity, will depend on the overall level of consciousness, but should only decrease in frequency when the patient has been fully conscious with a GCS of 15 for a period of time. Patients with risk factors or ongoing significant symptoms may require ongoing observation in the ED or following admission, even if the initial CT was normal. Patients who are anticoagulated or on antiplatelet therapy may also warrant prolonged observations. Studies have shown that up to 6% of these patients who are anticoagulated or on antiplatelet therapy may develop significant intracranial issues despite having an initially normal CT scan. What you're looking for specifically during this period of prolonged observation are signs of deterioration, and these include severe headache despite analgesia, vomiting, confusion or reduced GCS, seizure activity. All of these symptoms indicate the need for a repeat CT scan. There are other patients in whom it's clear that they may require admission, despite a normal CT scan. Ongoing decreased GCS. No one to look after them at home for the first 24 hours post-injury. And if someone has an abnormal CT scan, then that would be an indication for admission under neurosurgical care. It is in this approach to patients with a head injury where adhering to published, validated, evidence-based guidance ensures a consistency of approach to our patient management and to ensure that we don't miss subtle signs of worsening injury. In terms of the pharmacological management of these patients in the emergency department, it essentially centres around symptom relief. We should make sure our patients are well analgesed. However, we should avoid non-steroidal anti-inflammatory drugs in the acute phase due to the potential increased risk of bleeding. Antiemetics should not be withheld and administered with significant nausea or vomiting. Anti-epileptic medication is not administered routinely in the management of patients with head injury, however, used specifically if the patient is actively seizing or at high risk of seizing. So when do we discharge patients home? When it comes to safely discharging patients with a head injury from the emergency department, it is important that specific criteria are met. Firstly, the patient should be GCS 15 with no focal neurological deficits. If a CT scan has been performed, then this should show no abnormality. Patients should not be on their own for the first 24 hours since the discharge, and both the patient and the caregiver should have had both verbal and written instructions on recognising red flag signs of deterioration and what specific action to take. Despite the best medical and nursing care, complications can occur in this patient group. Intracranial hemorrhage may occur in the acute or subacute phase and may or may not require neurosurgical operative intervention. Post-concussion syndrome is relatively common post-head injury and may last for days, weeks or months. That being said, most patients, as I said earlier, will make a full and complete recovery. The greater the severity of the head injury, the greater the chance the patient will develop post-head injury seizures, although overall the chance of this is low. Patients with ongoing symptoms should be referred to a clinician trained in assessing and managing the consequences of traumatic brain injury, such as a neurologist or neuropsychologist. So what are the challenges and future directions in how we may manage these patients? Unfortunately, there remains inconsistency and inequality in the management of head injuries globally. Although there are clear, validated and evidence-based guidance, that are used inconsistently or not at all at times, which leads to ranging quality of care being delivered to patients with a head injury. The lack of access to appropriate imaging or specialist advice in developing nations is a barrier to optimal treatment. Conversely, in developed countries, the overuse of CT scans by not adhering to the guidance or due to defensive medicine, a phrase that I must admit I really do not like, leads to unnecessary radiation exposure and healthcare costs. All of this highlights the need for improved resource access and availability and a consistent approach using evidence-based medicine to the patient with a head injury. There are also exciting research developments which show promise in aiding the identification of potentially serious injury in patients who may initially seem okay. Biomarker technology is one area of particular interest, identifying proteins released from damaged brain tissue into the bloodstream that may provide direct biological evidence of brain tissue injury even when conventional imaging appears normal. And artificial intelligence. It seems we can't escape it in all walks of life at the moment. This, however, has the potential to aid clinicians in areas such as risk stratification and imaging interpretation, thus enhancing overall decision-making. Telemedicine would allow access to specialist advice from remote areas or where access to the necessary resources or expertise is difficult or limited, again, increasing the consistency of our approach to these patients. All in all, it's an exciting time for emergency physicians in the management of head injuries, one of the most common presentations that we see, yet fraught with potential danger if not managed properly. I'd like to thank you for listening tonight. We will have an opportunity to answer any questions shortly, and please feel free to contact me should you wish to ask me anything specific. Thank you very much.
Thank you so much, Dr. John. I will just handle the mic to Dr. Bastian, our senior consultant of neurology, and with the interest of advanced neurocritical care. Go ahead, Dr. Bastian.
Yes, thank you, Dr. Ayman, for handing me the mic. I would like to introduce Dr. Mohammed Al-Dawood, who is currently working as a consultant in emergency medicine in NEOM in the Kingdom of Saudi Arabia. And he has a strong background in both emergency medicine and critical care and neurocritical care. And he did fellowships in Michigan and Florida in the United States. And I just looked up his Twitter accounts, and that also mentions that he's a lifesaver. So let's listen to his talk.
Hello everyone. Before I start, I would like to thank the World Institute of Critical Care and Emergency Medicine Executive Committee for giving me the opportunity to present in this forum. So thank you for joining us today. My name is Dr. Al-Dawood Mohammed, and I'm an emergency and neurocritical care consultant working in NEOM Hospital in the north of Saudi Arabia. I believe we will have an exciting 20 to 25 minutes coming ahead, so why don't we just start? Today we are going to discuss the critical field of traumatic brain injury management. As all of you know, the TBI is a complex injury resulting from an external force and leading to spectrum of brain dysfunction. Our primary goal as a physician is to prevent further damage, what we call secondary brain injury, and to maximize the patient outcome for good and reasonable neurological recovery. On this talk, I'm going to review updated recommendation from the Brain Trauma Foundation Neurocritical Care Society and incorporate some recent trials evidence and walk through practice bedside strategy that are shaping care in our field. I have no financial disclosure. So traumatic brain injury constitutes a substantial portion of global health burden, with estimated 69 million worldwide. In the United States only, there are 2.8 million each year. Most of them is mild concussions or mild TBI. However, the moderate and severe TBI contribute to significant disability and death. And although the primary injury are generally not amenable to treatment or reversal, physician must focus, as I said earlier, to implement strategy to mitigate secondary injury and promote recovery. Unfortunately, we lack randomized clinical trials addressing many aspects of care on severe TBI patients, which means the strength of supporting data for several treatment aspects we have is relatively weak. At present, the management strategy in ICU is focused on the management of secondary brain injury through three main objectives, I would say, which are optimization of the cerebral perfusion, maintenance of the physiological homeostasis, and prevention and management of systemic complication. For the neurological assessment, we have two major scales, which are the GCS and 4 scales. The GCS has served us very well for decades as a standard in the trauma evaluation. I'm not going to discuss these scores in detail, but would like to let you know some experts consider the GCS motor score in isolation to be the best way to facilitate the rapid, reliable trauma triaging in the ER. The GCS remains the universal language or the lingua franca of the TBI clinical assessment. However, it falls short in an intubated patient and does not include a brainstem or respiratory function, and that's where the 4 score really excel. The 4 score offers more accurate assessment, especially in the neuro ICU patient, and it maintains validity even in intubated patient, making it highly applicable for sedated and comatose patients. The latest Brain Trauma Foundation's guidelines provide target for systolic blood pressure, ICP, and cerebral perfusion pressure with separate guidelines for the pediatric age group. The data show there are substantial reduction in the mortality with the adherence to the guidelines. The recommendation emphasized the importance of early and aggressive management of the intracranial pressure with aim to keep the pressure below 22. As data shows, sustained pressure above 25 associated with increased mortality and poor functional outcome. The cerebral perfusion pressure, on the other hand, is a critical target as well, and we typically aim for 60 to 70 millimeter of mercury. However, the optimal pressure is vary between and within individual patients over time, depending on the cerebral blood flow autoregulation and brain oxygenation. And that's why if we can monitor the autoregulation or brain oxygenation, we can personalize the CBV goal. The advanced cerebral monitoring may aid in the recognition and management of secondary injury mechanism to help prevent neurological deterioration. For example, as you can see in the image, the intrabronchial monitor provides continuous data and are relatively easy to insert. On the other hand, the EVD offer an added benefit of therapeutic CSF diverge. And while the non-invasive method like optic nerve sheath ultrasound and transcranial ultrasound are getting more popular and utilized, they are still currently adjunct and not replacement for the invasive monitor. So the question came, does using ICV monitor and severe TBI change in outcome? And the answer for this question came through 2 trials, the BEST-TRIP and the Synapses ICU. The BEST-TRIP trial from the South America published in New England Journal of Medicine in 2012 to compare 2 management strategies for severe TBI, one using the ICV monitor and the other one relying on the imaging and the clinical examination. It's a multicentric randomized clinical trials, and the result found there are no difference in the functional, cognitive, or mortality at 6 months. However, over the next few years, a lot of observational evidence was emerging in favor of the ICV monitor till the Synapses ICU trial came in 2021, which is a multicentric international observational study for approximately 1,300 patients with severe TBI, and to demonstrate the invasive ICV monitoring was associated with higher therapeutic intensity and lower mortality with the better neurological outcome. So as a bottom line, the recommendation is due to numerous observational studies demonstrating worse outcome in patients with ICV crisis, the ICV monitoring became the consensus best practice for patients with severe TBI in the developed countries. So while the ICV monitoring indications and target thresholds are provided by the Brain Trauma Foundation for the management of severe TBI, the management algorithm were omitted because of the lack of evidence. So a consensus-based guideline developed by the Seattle International Traumatic Brain Injury Consensus Conference, which provided a foundation for the institutional management protocol. This guideline consisted of what we call the tiered approach for the ICB management, which become very widely used in a lot of the ICU neurocritical care units on the ward. These guidelines consist of the tiered approach of medical and surgical intervention to treat the ICB, especially ICB crisis, and include the general, or what you call the universal tier 0 recommendation for all patients without or before developing the ICB, including the intubation, mechanical ventilation, positioning of the head to 30 degrees, appropriate sedations to decrease the metabolism, analgesia, close neurological and cardiopulmonary monitoring, and the prevention of known precipitants of secondary brain injury like fever, hypotension, hypoxia. Followed by tier 2 and tier 3, tier 1, tier 2, and tier 3. As you see in the chart, that chart for the tier 1 is mostly starting with the osmotherapy, maintaining the normal carbia, consider sedations like more deep sedation and anticonvulsant. For the tier 2, mostly adding the neuromuscular blockade and using the transient hypocarbia. And for the tier 3, which is adding more deep sedation with the barbiturate, so using the barbiturate coma and burst suppression, in addition to the surgical management with the decompressive crane. So for the barbiturates, just a few words about the barbiturates. They are very effective in lowering the ICU, but they do not provide any benefit in the form of functional outcomes or mortality. And also associated with the very bad systemic complications, including hypertension, respiratory depression, and also it's considered an immunosuppressant. In addition, the hypothermia, moderate hypothermia down to 35, 36 degrees centigrade. It's effective in the lowering the blood pressure, but also does not improve. There's no proof it does improve the outcome. The hyperosmolar agents are first-line therapy for the elevating ICB. Everyone knows there are two major drugs which are hypertonic saline, which come in different concentrations, especially 3%, 23% are the most widely used, and the mannitol. There are several studies have suggested the superiority of hypertonic saline over the mannitol and the suspect. However, the volume and the quality of comparative evidence has not warranted a formal Brain Trauma Foundation recommendation prioritizing a single agent over the others. However, in many ICU, as currently used, the 3% and the 23% concentration, the hypertonic saline, is favored due to volume expansion properties and sustained effect. And regardless of the agent you use, careful monitoring of the serum sodium and osmolarity is essential to avoid complication. The sedation and analgesia play a vital role in the management of patients with moderate to severe TBI in the ICU. Not just for the patient comfort, but it's reduce the cerebral metabolic demand and control ICB and decrease the oxygen consumption and the wastage product in the brain. Ketamine, propofol, midazolam are commonly used. Fentanyl is often the opioid of choice for analgesia in the ICU due to its fast action and shorter half-life. In cases of refractory ICB, deeper sedation or even burst suppression with agents like barbiturates and ketamine may be required. However, frequent assessment is a key, and in those patients who's placed in the deep sedations and burst suppression, only pupillary exam via pupillometer will be accessible. The antiepileptic drug should be initiated to prevent early post-traumatic seizure and their associated complication in high-risk patients. The risk factor for early post-traumatic seizure are a lot, including duration of the post-traumatic amnesia, patient with intra or extraaxial bleeding, skull fractures, penetrating injury. The Brain Trauma Foundation and Neurocritical Care both recommend 7 days of prophylaxis anti-seizure medication to prevent early post-traumatic seizure. But they are recommending again the use of anti-seizure medication to prevent late post-seizure or post-traumatic seizure, which is happening after 7 days. So what about the EEG monitoring? The continuous EEG monitoring has become a cornerstone in modern neurocritical care units. It helps identifying and diagnosing subclinical and non-convulsive status and seizure. monitoring the birth separation during the sedation, deep sedation, and even provide prognostic insights in comatose patients. So if your ICU had the capability, it's worth integrating the continuous EEG into routine care for the moderate to severe TBI patient. Keeping in mind, even the scalp EEG is not perfect. In one study, it missed up to 20% of patients found to have a seizure on comparison to the electrocorticography, which are the electrode placed directly to the cortex of the brain. So on behalf of the surgical intervention and decompression, the primary surgical evacuation indicated for the mass lesion, while in the absence of a mass lesion, the surgical decompression may be indicated for the management of the ICB. However, due to the absence of strong evidence, consensus-based guidelines provided indication for primary surgical evacuation of the mass lesion, which vary according to the hemorrhagic compartment, either supratentorial or infratentorial, while in the absence of a mass lesion, surgical decompression might be indicated for the management of the ICB. The decision to perform the secondary decompression for diffuse brain injury with associated intracranial hypertension are guided by two randomized trials. The first, which is the DECRA trials, which was published 2011, and its focus on the early decompression craniotomy on patients with severe diffuse TBI and ICB exceeding 20 millimeter of mercury for more than 15 minutes any time within the first 3 days, despite tier 1 therapy. They randomized the decompression craniotomy to the standard medical care, and while the craniotomy group showed rapid reduction in the ICB and significantly less time with the ICB crisis, they did not show any benefit in the mortality reduction, and there were higher risk of poor outcomes. Then, at 2016, and as the name suggests, there are secure ICB trials, which a large randomized study compared medical management to the decompression craniotomy as rescue therapy for prolonged elevated ICB. It's greater than the ICB is exceeding 25 millimeter of mercury for 1 to 12 hours. Refractory to tier 1 and tier 2 protocol compared to medical management. In this study, craniotomy was associated with improved mortality, and to be vigilant with this is higher proportion for good outcome, immunological outcome at 12 months post-injury, but not at the 6 month. So the bottom line, the updated neurosurgical practice guideline recommend against secondary decompressive craniotomy for early refractory ICB elevation in patients with TBI, but it recommends the procedure for late refractory ICB elevation to improve mortality and neurological outcome. On behalf of the neuroimaging, it is not sacred CT imaging the initial modality of choice for the traumatic injury. The CTAs have increasing use, especially if you suspect the neurovascular injury, okay, like in the patient with a posterior fossa fracture or penetrating fracture. For the plain CT, there are a lot of the classification system which is used to describe the pattern and predict the mortality. The most commonly used are the Marshall classification and Rotterdam classification system. There's a lot of the new system, but they are more complex. So just, these two systems are the most commonly used. On behalf of the MRI technique, there are the specific techniques like diffuse tensor imaging and MR spectroscopy, which can detect the subtle injuries like diffuse axonal injuries, which we are going to talk about for the next slide. And CT perfusion is getting more utilized as well, especially if you suspect hyperperfusion and ischemia after the brain injury. Diffuse axonal injury is a form of stretch injury resulting from acceleration deceleration force, which may contribute to the disorder of consciousness, and it has been associated with chronic neurodegeneration and cognitive outcomes. However, its impact on the prognosis in severe TBI is significant, and it had 3 major grades, as you can see in the slide. So the MRI is considered the gold standard for the diagnosis, especially for the sequences taking advantage of blood degradation products like the SWI and GRE, which shows high sensitivity for identifying hemorrhagic axonal injury, while the FLAIR sequence have shown the best sensitivity for identifying non-hemorrhagic axonal injury. Also, the grade 3 diffuse axonal injury has been associated with unfavorable outcome, but recent studies have revealed that the anatomical location of the lesion within the brainstem itself does matter. The dorsal lesion portending a worse prognosis than the ventral lesion. And finally, we should be aware even the identification of a grade 3 diffuse axonal injury should not be used solo or in isolation as a push for the care limitation for the severely injured patient. There are multiple tools which are used for the multimodal monitoring in the ICU. This monitoring allows us to integrate and combine real-time data, including the ICB, CBB, brain tissue oxygenation, and cerebral metabolism, which we collected via the microdialysis. So instead of treating a single numbers, we adapt our intervention to comprehensive cerebral physiology. This approach is especially useful in complex patients or in refractory TBI cases, and it has a major advances in neurocritical world. The brain tissue oxygen monitoring gives us a direct insight to the regional oxygenation in the brain. The level below 20 millimeter of mercury have been associated with poor outcome. Probes are placed in at-risk area in the brain, intraparenchymal, helping us to adjust the FiO2, hemoglobin target, and CBB. The brain oxygen monitoring is not yet standard everywhere, but the evidence is growing. There are several advanced cerebral monitoring techniques to measure the cerebral oxygenation, including the parenchymal brain tissue oxygenation and the jugular pulp catheter. For the later one, the level below 50% in the jugular venous oxygenation is concerning, and the recommendation from the Brain Trauma Foundation is to maintain the oxygen saturation above 50%. However, the saturation above 75 have also been associated with the poor outcome, probably potentially due increasing hyperemia, which is meaning increasing the blood flow and edema. Other recommended strategies in managing TBI patients in the ICU is to maintain glycemia and normothermia. Fever is an enemy of the injured brain. Even modest temperature elevation above 37.5 increase the metabolic demand and worsening the outcome. We use active temperature control to maintain the temperature between 36 to 37 degrees Celsius. The strict fever avoidance is a class 1 recommendation. On behalf of the therapeutic hypothermia is not commonly indicated and not recommended as a routine. The ventilation goals for the intubated patients is to maintain PaCO2 at the normal carbia with the range between 35 to 40 millimeter of mercury. We avoid aggressive hyperventilation unless we are managing acute ICB crisis and should be for a very short duration. The nutrition is a critical topic for patients with the TBI and the traumatic patient in general in the ICU and must be initiated early within the first 24 to 48 hours if there is no contraindications. In the early stage, the topic enteral feeding to maintain gut integrity might be useful, and the gastric residual is controversial topic which is still discarded in a lot of the ICU around the world. Many TBI patients develop gastroparesis, so placing a post-pyloric feeding tube could be considered, although the superiority is controversial in reducing the vomiting and aspiration risk. The nutritional goal must meet energy need to reduce catabolism, support immune function, and improve wound healing with high protein formula. On behalf of the DVT and stress ulcer prophylaxis, the TBI patients are increased risk of thromboembolism, but bleeding risk complicate the anticoagulation. That's why the mechanical prophylaxis should start immediately if possible. The pharmacological agents like low molecular weight heparin can be considered within 24 to 72 hours after bleeding risk is reassessed. Similarly, for the proton pump inhibitors are essential in the intubated patient and coagulopathic patient to prevent citrus ulcers. There are growing interest in the serum biomarkers like GFAP and UCH. They can be used both in the diagnosis and the prognosis after the TBI, and the FDA has approved in 2018 this biomarker to rule out CT abnormalities and then decrease the utilization of CT or unnecessary CT in mild TBI. In the ICU, these are not yet routine for severe TBI, and they are not clinically available in most trauma centers as well. And it takes several hours to get the result, which is limiting their current utility. However, initial research data is promising for its use. There are several experimental techniques to improve outcome, particularly recovery of consciousness, wakefulness, alertness after the TBI. The neurostimulant may accelerate recovery in patients with post-traumatic disorder of consciousness. There are limited evidence support the use of methylphenidate and amantadine as off-label to improve the rate of recovery between 4 and 16 weeks post-injury. Despite the advances in the field, the prognostication remains a difficult task for intensivists involved in the care of patients with TBI. The long-term follow-up studies show that continued functional recovery may occur up to and beyond 10 years post-injury, emphasizing a need for prognostic humility and shared patient-family decision-making. In addition to the EEG, MRI, scan biomarkers, the somatosensory evoked potential become more popular and may aid in the predicting the 6-month recovery of consciousness and functional outcomes. In regard of the EEG, the background EEG were independently associated with outcome, and the presence of more normal background indicate a better prognosis, while patients with the severe interictal pattern were associated with increased severity and poor cognitive but not functional outcome. And due to significant injury heterogeneity, the outcome prediction following TBI is challenging. We have 2 validated clinical predictive score models for prognostication, which is the CRASH and IMPACT models. Both of these models designed to predict the 6-month mortality and unfavorable outcome following a blunt TBI based on a clinical, radiographic, and laboratory data present on admission first 24 hours and not for the serial use. A common predictors for poor outcome in all of these modules noted to be the older age and lower GCS scores. The prognostication following the TBI is evolving in process, and the studies show continuous recovery in patients well beyond the 6-month targeted by the most of these models, which emphasizing the limitation of models such as CRASH and IMPACT and the need for prognostic humility. There is also a newly innovated with MOST module, which is demonstrated outperformance over both of these modules, the CRASH and the IMPACT, in predicting in-hospital mortality within 30 days. However, it still needs further validation. So the future direction in the TBI care. As we look ahead, the AI and precision medicine will increasingly shape our TBI care. The platform that integrates multimodal data, including the intracranial pressure, EEG, brain oxygen saturation, imaging, etc., can help us personalize therapy in real time. In addition to telemedicine in the neurocritical care, we'll also expand the access to the expert level care in resource-limited area, which would improve care for such patients. The next border is not just managing the TBI, but anticipating and preventing secondary injury before it happens. The paroxysmal sympathetic crisis, or STORM, is a syndrome of sudden onset and recurrent transient episode of tachycardia, hypertension, tachypnea, fever, and motor rigidity associated with transient surge in the catecholamine level, which is happening in approximately 1/3 of severe TBI patients. It happens more in young male within 1 to 2 weeks after the injury and associated with worse short-term outcomes. It may be confused with a lot of the differential like seizure, status, sepsis, BE, and other differential, and it must be taken seriously and treated vigorously. It's important to consider the diagnosis and start the management with multimodal treatment, including the abortive medications, which is kill the current episode, and the preventive medication to decrease the recurrence of the future events. Thank you for taking the time to attend my lecture today.
Very nice presentation, Dr. Bastian. Do you want to start the discussion session?
Yes, sure. There were several questions, and to start with one of the last ones, that was in patients that have blood in the brain, so brain bleeds because of the trauma. Should we start DVT prophylaxis? Maybe Dr. Ayman, can you reflect on that?
Yeah, usually the recommendation is don't start anticoagulation until you secure the area that with the bleeding. So the most important part is to make sure that there's no any active bleeding. Sometimes we manage it similar to the subarachnoid hemorrhage. So if we do it and we can't find it, sometimes we can go to a conventional angio just to make sure that it's secured before we start the bleeding. And usually the bleeding after an intervention, at least within 6 hours of close monitoring. There's also one question regarding the, let's see, somebody mentioned, I think Miss John or Dr. John. So the question is as following: that is there a role in of corti or of steroid in severe traumatic brain injury? So according to the crash trial, which happened like almost 20 years ago in 2000, I think 4 or 5, they found like using of high dose of cortisone and even low dose, a moderate dose of methylpred, actually it increased the risk of death. After this, multiple trials or multiple RCT done without any evidence that it's benefit the patient to start any kind of cortisone. One trial, if I remember correctly, with the subcategory with the, but the number was very slow, so it's not part of the recommendation. So just as a bottom line, there's no steroid is no, it's not recommended in severe traumatic brain injury. The main focus should be on the supportive care, blood pressure and intracranial pressure management, and surgical intervention in case it was needed. I think for Dr. John, there's few questions.
There was a question, Dr. John, also on pediatrics. So your talk mainly had to do with adults, of course, but maybe you can reflect on the kids briefly.
Yeah, so I think the indication. So I think so. One of the questions in terms of indication of CT scan. So it's essentially the same in pediatrics. And one caveat to that is patients that are less than 1 year. Where obviously the assessment of patients that are so young are very, very different. And you would have a lower threshold for CT scan in those patients, particularly if there's evidence of any scalp bruising or scalp wounds, such as a laceration. And the other thing to always think about in children that are very, very young is the possibility of non-accidental injury as well. So to keep an open mind when assessing your patients with that in mind.
Thank you.
There is one question. It says, is there any complication of the advance, as Dr. Muhammad mentioned previously, in the severe traumatic brain injury? Is there an adverse effect or complication of the invasive monitoring? So definitely, it's the same as any invasive procedure in the body. So we can start with either local hemorrhage, which is significant, especially in the traumatic brain injury. But most important is the false information. So other than the malfunction and obstruction of the drain that we are using to monitor the intracranial pressure, there is always a problem with the people start to focus on the number and they forget the clinical picture of the clinical signs they are seeing on the patient. So this is a very common problem. That's why whenever we do a neuro unit or neuro ICU unit, usually focus and train our staff that don't focus on the number, because the numbers always like go up and down according to the malposition or obstruction of the drain. But whenever you see any changes in the number, you need to check the patient right away. And even we put a schedule for them to check and examine the patient. One of the common complication also is infection, because as you can imagine that we put in a foreign body in the brain itself or in the area around it. So infection is one of the also known complication. It's not very common. But again, some experts recommend using a short-term antibiotic coverage just as a prophylactic for procedure, not for long-term. So you don't need to cover the patient for long-term antibiotic. If you will use, you can use up to 24 or 48 hours and then stop it, unless there's any sign of infection either from outside or any sign like viruses going up or any of the inflammatory markers is going up or clinically. Back to you, John, or Dr. Bastian, if there's any more questions.
Yeah, there are two questions from Dr. Mulamba. And one is, does head elevation of bed have a role in the management of head injury? And I think, yes, it's quite a common practice to elevate the head between 15 and 30 degrees to improve the cerebral circulation by lowering the venous pressure. So the answer to that question is yes, there is a role for head elevation. And second question of Dr. Molamba was, how long should seizure prophylaxis be given after head injury? And well, this is not really evidence-based. This is more like expert opinion. Personally, I'm used to give it like 6 weeks. And then we see them in the outpatient department, the good ones at least. And then we decide to stop it usually. Maybe also a question for you, Dr. Ayman. Something I remember from long ago to work with the salts, to have a high natron, to hypersaline in the patients with brain injury. Is that still something that we do to aim at a very high blood sodium?
Yes, so whenever we have increased intracranial pressure, most of the recommendation is just to go with the increase the sodium load and osmolarity just to overlap the high pressure in the brain. So with this, because I'm getting the alarm that we are reach our limit and timing, so I would like to thank you all for attending this webinar, and I hope you enjoyed it and learned something. It is like a sample from the fellowship, and as you see, like also in the both lectures from the ER and triaging for the mild and moderate up to the severe and the monitoring and the complication, all these topics will be in dedicated weeks, and it will be discussed in length and in deep, and also you will have a chance to have an open discussion with the expert in all these material or matter or topics. And I really hope that you all find yourself like registering our fellowship, and just for the best of all of you. And back to Prof. Amro, our WICCM president, to give us like just the ending.
Thank you so much, Dr. Ayman, Dr. John Thompson, Dr. Bastian, Dr. Mohammed Dawood for this fantastic webinar. Just housekeeping issues. Tomorrow, you will receive the recorded webinar. We already have your cell phone number, your email address. We're going to share the YouTube link for the recorded webinar. By next week, all attendees should receive also a certificate of attendance. Also, if you are not part of our WhatsApp group, that we are delivering free educational information and take-home messages in neurocritical care, please feel free to join us. We are big community. We are trying to disseminate and share knowledge when it comes to neurocritical care. So please join. I already put the WhatsApp group information. And we'll be in touch with you shortly. If there is any question that hasn't been answered, I think Dr. John Thompson and Dr. Mohammed Dawood, Dr. Bastian, Dr. Ayman will be happy to answer it through the email or in the WhatsApp group. So thank you again, and we will have our next webinar early next month. So we'll send you information about that. We'll be happy to disseminate more and more knowledge when it comes to the neurocritical care field. Thank you.